All right, everybody. Welcome to this relatively brief review session for the trauma exam on Monday. I apologize that it's coming out so late. It's a combination of things. One being that there's not a whole lot for me to put in a review that benefits more than the study guide that's already up. But I wanted to go through and pick out some of the hot topics from the exam to just guide you in the right direction of what you're studying. So this will be shorter than the other review videos just because there's less direct topics for me to really talk about. I would focus mostly on the study guide. Take a little bit of time to watch this video. It should be pretty short, just to get an idea of maybe what things to lean in the direction of. I've written down maybe a dozen concepts that I think hit hard on several of the questions throughout or several of the groups of questions throughout the exam, so that it is, I don't know, maybe a little bit more clear what to go and look at to study. First things first, just like your medical exam, ABCs need to be on your mind more than anything else. The ABCs are still our highest priority on these calls, and they come up just as much on these calls as they did on our medical calls. There's not a lot of questions on this exam that just say your patient is alert and oriented and their arm hurts. What should you do? It's a little bit too elementary to test you guys on, so we really are going to focus mostly, or not mostly, but we are going to focus a lot on the ABCs. When we separate the exam questions from the ABCs, or some you'll see in some of these exam questions, while the ABCs are being, apologies, I don't know exactly where I left off, but somewhere in the neighborhood of ABCs are really important. There are a few questions where it will say your partner is handling the ABCs already. What should you be doing next? And we've talked a little bit about how on most of these calls in the real world, we're going to double up on a handful of these things. Someone's going to be checking the ABCs, somebody's going to be doing a scan for bleeding, somebody might be, starting to take some vitals. Maybe you send a police officer or a firefighter to go start getting a sample history. The framework that your book follows, and you can find this in your book, is right along the lines of ABCs first. ABCs always come first after scene safety. Once you've done your ABCs, you're going to request additional help if it seems like it's going to be necessary. And then your book likes you to do the head-to-toe exam before you take your vitals. And I want to point that out just because it does come up on a couple questions on this exam. Real-world scenario-wise, usually if we have a partner or if we have a couple people here at one of these big traumas, we can bang out several of these things all at once. But remember, in your test questions, you're the EMT. You may or may not have a partner. So if it doesn't say that there's somebody already doing the ABCs, you got to get on the ABCs. If it says there's somebody already doing the ABCs, then probably they want you starting that secondary assessment, starting that head-to-toe assessment to look for these other possible injuries that you could find throughout that didn't come up immediately in the ABCs because they weren't an airway problem or exsanguinating hemorrhage or something like that. And then after we do the ABCs, then we really start talking about getting vitals as the flow chart from our textbook goes. I understand that, a lot of times we can do multiple of these things at once, but when we talk about test questions, that's the flow plan that we want to follow. One of the things I want to tell you guys to point back out or to take a look back at, and I think this made it onto your study guide, is go back to that trauma overview chapter that we spent the half class on a couple weeks ago. I know it was a while ago. And take a look at the different kinds of motor vehicle collisions that we can see, meaning getting rear-ended, front-end collisions, side collisions, rollovers. Take a look at those different types of collisions and the kind of injuries that we expect to see from each of the different types, or the most common injuries that we see from each of the different types. We get a rear-end collision, we get knocked forward, and we know that causes those coup contre coup injuries. When we have side swipe collisions, we know that affects our aorta more than a lot of our other collisions do. So go back, take a look at those mechanisms and our commonly associated injuries that go along with them. Visceral versus somatic pain. Now, those vocab words themselves aren't super important. I think I'd have said them in class before, but what I want to point out is the importance of recognizing that when your patient presents with pain that feels like it's inside them, we want to prioritize considering possible injuries that also are inside them. So if we have a patient that feels like they have pain inside their chest, we palpate down their chest, we're doing our inspecting and palpating, we're pushing on the ribs, feeling for any deformities. If they feel like the pain is inside their chest, they don't say anything when we're pushing along, palpating on their chest, then we shouldn't go into that thinking, oh, this is probably a rib fracture. We should go into that considering maybe this is, a pulmonary contusion, a bruise directly on the lung, something like that. And when our patient is complaining of pain that feels like it's on the surface, we want to prioritize thinking about the things that would be on the surface. Soft tissue injuries, bony injuries, things like that. And maybe set the internal ones not aside, but a little bit further back in our mind as to what this pain itself is referring to. That seems like a weird thing to bring up. When you see the test question, I'm sure some of you will immediately know why I chose to talk about that. But I wanted to throw those vocab words out there as well. Somatic pain is pain that we feel on the surface. Visceral pain is pain that we feel inside. We usually refer to that as it relates to the abdomen and the chest. But if you look at like the textbook definitions, they can be used more broadly. I've told you guys before that when I write charts on any patient who has head pain, I always specify if it's traumatic head pain, whether or not it was visceral or somatic. If someone that has visceral head pain, they get hit in the head and now they feel like they have a headache. Well, that means that, I'm a little bit more concerned about their brain. Somebody that gets punched in the face and now their face hurts, I expected that. We still need to do our assessment of those patients to make sure they don't have things like skull fractures, facial fractures, mandibular fractures. But if they're complaining that their pain feels like a headache, I'm a little bit more concerned about the brain that's inside their skull, because their brain is honestly a little bit more important than the face or their mandible, things like that, as long as those aren't becoming an airway problem. Kind of a disappointing one to talk about, or disappointing in what the answer ends up being. And there's several questions on this exam where it comes up, what do trauma patients need from us? And the harsh reality of this question is that trauma patients need trauma centers. We will do our best to manage our trauma patients in the field, but trauma patients need trauma centers. Trauma patients need blood to replace the blood that they have lost, something that we do not have on ground ambulances, particularly in New York. And trauma patients usually need surgery to go in and repair whatever might be bleeding inside them. There's really nothing at all that we're going to do about bleeding inside of a trauma patient. So first and foremost, trauma patients need to go to trauma centers, places where they can get the care that they need to actually keep them alive. We do our best to stabilize them, and our job in stabilizing them is really, really important. But there was a study that came out last year, a little disappointing to read as someone in the EMS community. But there was a study that came out that showed in terms of blunt trauma, that was non-penetrating, there was no difference in outcome between that patient that was transported by an ambulance and that patient that was just thrown in the back of a police car or a friend's car and driven mock Jesus to the hospital. We didn't see any difference in outcomes by those patients getting ambulance transports. And the authors were very generous in saying that, we left many, many things out of this study. There was no differentiation between ALS patients and BLS patients, response time, type of receiving hospital, all those things got left out. It was just a really broad overview to start looking at this topic. But I think it really helps emphasize the point that what trauma patients need is trauma centers. A lot of these resources that are going to keep them alive are resources that we don't have. So if we can get them safely packaged and manage those ABCs, then we need to get lasering down to where they can provide the appropriate care for these patients, which is at a trauma center, preferably a comprehensive trauma center, a level 1 trauma center. Usually these days that comes in the form of a university hospital, but not every level 1 trauma center is a university hospital. So patients that are experiencing big trauma need to go to places where they can care for big trauma. Fortunately, those places are not in the back of an ambulance. I want to talk a little bit about abdominal organs, and I drew a picture because I know that you guys watch these videos for my art. These are some of the most famous and flavorful organs of the abdomen. So we have our esophagus that comes down here and it goes into our stomach. Our stomach, I just drew your small intestine as this back and forth thing here. Obviously, it's quite a bit more loopy than that. But we have our small intestine in here. Small intestine eventually becomes part of our colon or our large intestine, and that loops around and comes down, exits through our anus. Along this GI tract, this is our tube of outside that passes through the inside of us. We have our appendix over here. That's what this little dangly bit I drew on here is. That's not a big concern for us when it comes to trauma cases. Usually we talk about appendix as being a medical problem when they become inflamed. We also have our gallbladder here. That is coming off of our liver and going down into our GI tract. That's secreting that bile to help us digest fats. Another one that's not usually a big problem in terms of our trauma cases, but a big medical topic for us. Up here we have the liver. The liver is a really big deal for our trauma patients. And so are these little beans that I have colored in sort of behind the stomach, as well as this bigger bean that I have colored in over here. That is the spleen. Those are our 2 kidneys, and then obviously this is the liver. And the reasons that I've colored those in is because they're solid organs. Solid organs are a really, really big concern for us when it comes to trauma patients, because solid organs are usually solid because they're super, super vascularized. Super, super vascularized means super, super full of blood. So when we get traumatic damage to our liver or our spleen or our kidneys, we can bleed a lot all of a sudden into our abdomen, which is a place that we cannot then get in to stop that bleeding. That's why our trauma patients need trauma centers, so they can deal with things like this that are going on. So there are still a few questions on this exam that ask you purely just to localize within the abdomen, use your understanding of where the abdominal organs are and a patient's presenting pain and symptoms to figure out what might be injured. But a couple of those questions also give you little hints that point you in the direction of, is it a solid organ or is it a hollow organ that's injured? So if we have patients that are presenting with signs of shock and a distended abdomen, that sounds like they might be bleeding into their abdomen. If we talk about, the stomach and the liver really overlap a little bit right here. I'm just trying to do my best to draw. If we're talking about pain that's, somewhere in this area, well, it could be pain that's coming from trauma to the stomach or trauma to the liver. But if we're talking about a very full distended abdomen with signs of shock, it's probably going to lean us a little bit more in the direction of the liver, because when the liver gets damaged, it's going to bleed a whole lot. When the stomach gets damaged, it can still be incredibly life-threatening because it's going to release all that gastric contents. But those gastric contents are probably going to cause a little bit slower of a problem as we develop peritonitis, whereas that liver laceration is going to cause an enormous amount of bleeding very quickly all into our abdomen. So here on the trauma exam, we ask you not only to be able to differentiate the location of the organs within the abdomen, but I also expect you a little bit to be able to put together solid versus hollow and some of these presenting symptoms to get an idea of, okay, this seems like it's a bleeding issue, that is probably a solid organ. This seems like a pain issue, that might more likely be a hollow organ. The other thing about our hollow organs is that most of our hollow organs eventually lead to an external orifice of some kind. So, if our colon or something is damaged, well, eventually that's going to go to our anus, and we might see some frank rectal bleeding. If our ureters or our bladder is damaged, well, that eventually is going to go to our urethra, so we might see hematuria, or blood coming out in our urine. There are a couple exceptions to that. You know, we're not going to immediately see gallbladder injury or pancreas injury because the blood isn't going to get as smoothly into the GI tract as it does if we have, you know, some kind of damage to our bladder, which very quickly can produce blood coming out in our urine. But you know, when your test question tells you, oh, your patient presents with frank hematuria, then and they were hit by a car roughly in the pelvic region, you know, they were hit by a sedan or a crossover, then we might want to think along the lines, okay, well, blood had to get into the urinary tract somehow. Two ways that usually happens: it comes from the kidneys or it comes from the bladder. And if they were hit in the pelvic region, well, that's not where the kidneys are. So it pushes a little bit more in the direction of thinking about our bladder. I want to briefly just mention keeping in mind the phases of shock. And by phases of shock, I mean the flow in terms of presenting symptoms. So our patients, as they start to, in the traumatic sense, we generally are talking about hypovolemic shock. So as they start to lose volume from this bleeding, we start to see some anxiety, and then, you know, the tachypnea starts to come in. Then a little bit later on, we'll see that heart rate start to go up to start to compensate for this blood loss. That anxiety starts to turn into that sense of impending doom. And the main thing I want you to remember, just like we talked about in the medical chapter, is that that drop in blood pressure is our late stage sign of shock. That drop in blood pressure is our, oh crap, I might already be too late to just be realizing that my patient is in shock. So keep in mind that when we're reading a question, we need to look out not just for it to tell us that the blood pressure is 60/30, but also that your patient is anxious and breathing quickly, or that your patient's blood pressure is normal, but their heart rate is 125. You know, their heart rate's up for a reason. If we have a high mechanism injury associated with that, or if we have known bleeding that we can clearly see because it's external, then we need to keep in mind that that patient is probably already going into shock, and we don't want to wait for blood pressure changes to start doing our treatments for it. The rule of nines. The rule of nines, I'm really just reminding you to go look at it. I think it comes up in maybe 3 or 4 questions. A couple of them are very direct, where I'm asking you, I'm telling you, here's your patient, here's where there's burned, what's the percent TBSA? And then there's a couple that are more in a discussion of if we have this much percent TBSA, what does that mean? Or what does it mean for this person to have this percentage of burn versus this person to have this percentage of burn? And you know, maybe which one of those patients should we consider going to a burn center or flying them? Some that are more a little bit abstract than that, and a couple that are very direct. Your patient has burns on the face and the anterior neck and the anterior chest. Add it up. Well, this is, you know, probably about 4.5. This is 9 right here. So we put those together and we say that it's probably like 13.5, 14% burned. Keep in mind when you're doing your rule of nines calculations that we try and make the questions pretty easy and direct. Like, I would try not to give you a result where you're going to need to get any more specific than 4.5. Probably wouldn't even ask you to get as specific as 4.5, but I can't remember off the top of my head if I do in that one question. Certainly nowhere where you need to get into the 2.25 territory. So if you're starting to do a lot of math for one of these questions, pause and try and think back to your rule of nines. You might be overthinking something along the way there. And keep in mind our other piece of the rule of nines, and that is not part of the rule of nines, but another part of TBSA, and that is that our palmar surface area is about 1% of our body. Your patient's palmar surface area is about 1% of their body. All right, not my favorite topic to talk about, but head injuries. When we talk about head injuries, neck injuries, really any mechanism that has any possibility to impact the spine at all, our book wants us doing full spinal immobilization. Now, we have moved on mostly in the real world with our good research to, at the very least, with these patients doing spinal motion restriction and not spinal motion immobilization. We want to minimize that spinal motion, not strap them as hard as we can to a backboard. But in terms of our test questions, when we have test questions that say that somebody's head was hit and snapped back, or they got hit in the neck, or that they got hit in the back, then they do still really want to see that full spinal immobilization. Last couple things, like I told you, this is going to be a quick video. Cushing's triad. This came up in 2 or 3 questions on the last exam, and I really felt like we hit it strong enough in class, but then it wasn't our highest performing question on the exam. So I want to go over it again. I drew it out in a nice little triangle for you. Cushing's triad are signs of increased intracranial pressure. Can we see some of the Cushing's triad symptoms with ischemic strokes? Yes. But really, when we think of Cushing's triad, we think of swelling of the brain or increased blood in the brain from a brain bleed, something more along those lines. We don't normally think of our ischemic strokes when it comes to Cushing's triad. There was that one question on the last exam that asked very directly, here's a patient with Cushing's triad symptoms. Which of the following do you think is going on? And cerebral occlusion and cerebral hemorrhage were both options, and we were split pretty 50-50 on that. So maybe we didn't touch on it well enough in class. That is, these are really signs of increased pressure within the brain, mostly, which is going to come from either the brain is getting bigger, the brain is swelling, or there's more stuff inside the cranium than there normally is, and by that we mean we're bleeding into our brain. Cushing's triad. Irregular respirations. Sometimes you'll see that written as slow respirations. Our test questions, I've tried to be good and pick out the ones that specify that they are irregular respirations. But if you're presenting with this other ones and it says slow respirations, usually they're trying to kick you in the Cushing's triad direction with that as well. Irregular respirations, bradycardia, and hypertension, or I like to specify a wide pulse pressure. So not necessarily just hypertension, but a big difference between our systolic and our diastolic blood pressure. A lot of times in these questions, we'll put it as 190 over 100 or 200 over 100. Now keep in mind that if our prototypical blood pressure is 120 over 80, that pulse pressure is 40. If I'm presenting you with a patient who's 190 over 100, their pulse pressure is 90. That's over double the size of our normal pulse pressure. It's very, very high. So irregular respirations, bradycardia, and a wide pulse pressure, or just more simply hypertension, severe hypertension. Those are our signs of increased pressure within the brain or within the cranial vault. And normally by that we mean swelling or bleeding. All right, and then last but not least, just looking quickly at the Glasgow Coma Score. Now, I wrote this way too small for it to in any way be readable on the screen, but I thought that it was kind of cutesy the way that I wrote it out, so I left it like this anyway. Our Glasgow Coma Score, max score is 15, 4, 5, 6. The highest score we can get is 15. The lowest score we can get is 3, because in each of our categories, the worst assignment that we can get is a score of none. No eye movement, no verbal at all, and no motor movement at all. And each of those is a 1. So the lowest GCS we can have is a 3. Just looking quickly at each of them, the GCS for eyes, a perfect score, a score of 4 is that they open spontaneously. A score of 3 is that they open in response to verbal stimuli. A score of 2 is painful stimuli opens your eyes. And a score of 1 is we can't get your eyes to open at all. Notice that this is the same as our AVPU scale, or our AVPU. Alert, responsive to verbal, responsive to pain, unresponsive. That is the same scale as AVPU. In terms of our verbal, perfect score is 5 points. You get 5 points if you are oriented. So not only are you up and talking to me, you know what's going on. To get 4 points, you need to be confused. So you're up, you're talking to me, but we're not really sure what we're talking about here. A score of 3 points is that you're saying words, but they're not really sentences. You're kind of just spewing random things out. A lot of times our postictal patients that are coming out post-seizure will work their way up this chain. And when they're at the words phase, they might say like, seizure, you, wife, things like that. To get 2 points, you're just making sounds. So there's noise coming out of you, but it's not words or sentences. We're not having a conversation. It might just be moans or screams. That's a score of 2. And then if you're not making any noise at all, that's a score of 1. None. Motor. Motor is probably the trickiest one that trips the most people up. Score of 6. Perfect score for motor means you obey commands. Lift up your arm. 6 for 6. Score of 5 means that you can localize where I'm touching you, I guess. Score of 4 withdraws from pain. If I pinch you, even if you're, not really with it, if I pinch your trapezius over here, then this should pull away from me. And importantly, for that score of 4, just this should pull away from me if I pinch right here. Your body should have a natural response to want to pull away from that. Score of 3 gets down into decorticate posturing. Big word, but decorticate posturing is when we are still kind of withdrawing from pain, but our body can no longer really localize where that pain is, so we withdraw everywhere. And sometimes we'll see this written as abnormal flexion. So I pinch here, and the whole body squeezes up like this. We call that decorticate posturing. What I learned when I was a student, what has continued to work well for me up until this day, is that in decorticate posturing, you go towards the core. And it's also easy to remember that going towards the core is the slightly better of the score of 3 and score of 2 on the GCS motor scale. Because our natural instinct, if we can't localize pain, should be to reach in and protect everything. So that's our score of 3, our decorticate posturing. And then our, second to last, our score of 2, our decerebate posturing. That is our worst kind of posturing. So I pinch right here, and your body opens up to me. That is worse than decorticate posturing. We've lost our natural protective mechanism that we close up to try and protect ourselves. And then a score of 1 is none. I pinch your shoulder, I slap you across the face, no matter what, you're not doing anything. That's all I have. Quick dozen or so notes that I wrote down, things to go back and look at. Like I said, I don't have as much to use this time to point you guys in the right direction, but I hope that was a helpful start at least. And I know this video is coming out late. Hopefully a few of you have a chance to watch it today. Maybe some more people have a chance to watch it on Monday. And I tried to keep it on the shorter side so that you could watch it. You could watch it at 1.5 or 2 times speed, and maybe pick out a few things that you hadn't looked at beforehand. Look at the study guide. The study guide is going to be a much better resource than this video is for this particular exam. If you have any questions, send me an email. I will be sleeping most of today probably, but I'll try to get to your emails tonight if I get them. During the day today, I'll be at work again on Sunday night. And then on Monday, once again, you can email me, you can call me, I'll be around on Monday.